Well, welcome everyone to our On the Pulse series. We're so glad to be back with a new season of offerings. I am Chris Fortman, the CEO of the Minneapolis Heart Institute Foundation, and I am so glad you made the time to join us today to hear a little bit from our physicians. And before we get into our keynote speaker, I would love to give you a little background on the Minneapolis Heart Institute Foundation. So we are an independent nonprofit research and education organization, and our great work is made possible by our unique partnership with the Allina Health Minneapolis Heart Institute. So as a research and education organization, we partner with very busy cardiologists and surgeons who have real-time questions, and we bring that all to life, and all of that work improves our clinical practice. Here are some examples of how this happens. Our mission is to improve cardiovascular health through innovative research and education. So right now we have over 200 studies underway, touching the lives of over 2,000 patients. And this is physician-initiated research and industry-sponsored clinical trials. And it's so important to have that mix and that number of studies because it offers options to our patients. In addition to the research side, we are committed to educating the community and the next generation of healthcare providers. One of our great programs is our internship program, where college students come for the summer and partner with a physician and a research staff to do real-time research and often present at conferences. Most of our alumni are either practicing physicians or currently in medical school. We also provide ongoing continuing medical education opportunities, community education, and of course are very committed to publishing all of our research findings in peer-reviewed journals, and that number is about over 200 annually. And this is a special year for us because we are celebrating our 40th year anniversary, and we've been able to continue this work for the past 40 years because you can see many of our values to the right. That's operating with innovation, ensuring impact, being agile, really leveraging our passion, always expecting excellence and quality, and most importantly, having those options for our patients. Here we have a summary slide of really what has changed from 1982 to 2022. As you can see, the aqua colors show the numbers of MHIF, the number of physicians at 13, staff at 5. And you can see where we are today with the partnership with over 100 physicians, with 80 plus staff ready to support research and education opportunities, a $16 million investment, and again, publishing more than 3,000 peer-reviewed manuscripts in this time. And the story goes on. I just wanted to share this with you because we are so excited, not only to celebrate the last 40 years, but to look forward to the future. And this is probably one of the most important slides. And this is really to say thank you. We are so grateful for the community partnership and the many people and organizations that make this work possible through their very generous philanthropic contributions. So with that said, it is time to get on to our keynote. I am pleased to introduce our speaker for today, Dr. Jay Sengupta. Dr. Sengupta is board certified in cardiac electrophysiology. He specializes in the treatment of arrhythmias and performs procedures including catheter ablation and cardiac rhythm device implantation and management. He is the director of the Heart Rhythm Science Center at the Minneapolis Heart Institute Foundation. With that, here is Dr. Sengupta. Thanks.
Well, thank you, Chris, for the introduction. I'm really thrilled that this segment is called On the Pulse, because as an electrophysiologist, we deal with the electrical basis for the pulse, so it's very appropriate for our work. What I'd like to talk to you about today is heart rhythm disorders and the impact on our daily lives. And I want to put you in the shoes of a heart rhythm specialist or cardiac electrophysiologist like myself. And in order to understand heart rhythm disorders, we also have to understand what the normal conduction system looks like and how it works. So we'll talk a little bit about that today. I hope to address common questions that you have about heart rhythm disorders, or as we call them, arrhythmias. And a common question that sometimes comes up is what is the difference between an arrhythmia, a heart attack, and a murmur, as these are common terms that I hear from my patients. So we'll talk about that as well. I hope to share with you the scope of the problem and dealing with heart rhythm disorders with some statistics. I think you'll be quite amazed as how many people are affected by heart rhythm conditions. And we'll focus on a couple critical areas in cardiac electrophysiology in particular, because the field is so vast, it would take days, if not longer, to go through each area. But I want to focus in particular on atrial fibrillation and sudden cardiac death. And it appears that a lot of our patients have questions related to these particular areas of cardiac electrophysiology, which are very important. And through all of this, at the end, I hope you'll find that with new technology and innovation and a passion for treating these conditions, that we can do a lot to help people with heart rhythm disorders. And that may include reassurance, it can include medications, that we called catheter ablation. So that is essentially the roadmap that we're going to follow during this presentation. I want to start by showing you this beautiful representation of the electrical system of the heart. And I think a lot of people are surprised to find that the heart has its own electrical system, which is quite remarkable. And that electrical system has its own power generator, if you will, and that's called the sinus node. And that exists at the top of the heart in the right atrium, the top chamber on the right. And that typically initiates the electrical impulse. And that electrical impulse then spreads like a wave across the top chambers, the atria, and then through an electrical bridge. We call that the AV node and His bundle. And that essentially is like a cable that connects the top to the bottom chambers. And the electricity flows through that cable and through additional cables to the right and the left side of the heart. And these cables are called the right bundle branch and the left bundle branch. And that electricity, that electrical innervates the heart muscle tissue. And before, everybody knows that the heart is really a pump that circulates blood, but before each pumping cycle, the heart has to electrically activate in order to mechanically contract. And that electrical activation is what we call depolarization. And depolarization happens in each heart muscle cell, whether that cell is part of the muscle itself or part of the electrical system. And that depolarization is represented in this diagram here. And that has to do with the flow of electrical ions and through these channels that exist in each heart muscle cell. And those channels involve sodium, potassium, calcium, among other ions. And that flow of electrical ions is what initiates and sustains that flow of the electrical impulse or depolarization. And this diagram represents all those depolarization signals occurring through the heart as the impulse travels from the top chamber, from the sinus node, through the atrium, through the bridge, and down to the bottom chambers of the heart, the ventricle. And you might say, well, what is the significance of all these electrical action potentials and depolarization and repolarization? Well, think of it this way, that it is those electrical signals that together make up the signals that we appreciate on an electrocardiogram. And many of you have seen an EKG before. Many of you have had an EKG when you visited your doctor's office. And this EKG is a summation of all that electrical activity that's happening inside each of the heart muscle cells put together. And with this EKG, we can appreciate the electrical activation or depolarization of the top chamber. That's represented by this small deflection called a P wave. The time that it takes from the top chamber to get to the bottom chamber, that's the time in between these deflections called the PR interval. And then the electrical activation of the bottom chambers, the ventricle, that's represented by the QRS complex. And then the ventricle has to reactivate or repolarize to get ready for the next electrical cycle and cardiac cycle and heartbeat. So think of the heart now as really an electrical organ that has its own electrical system that has to function appropriately, normally, for the heartbeat and to be normal and to have a normal pulse. And that is what we appreciate as the EKG, is the electrical conduction through the heart. Now, before the specialty cardiology, at one point, many years ago, had only EKGs. They didn't have these fancy imaging tools that we now have today. This is an example of an echocardiogram image. We also have fancy imaging tools like a cardiac MRI and a cardiac CT. But before they had all this, they could actually look at an EKG, and not only could they tell if there was a problem with the electrical conduction system, as in this case, this is illustrating a delay or a slowdown in the right bundle cable, the right bundle branch, and this is called a right bundle branch block, illustrated by this change in the electrical deflection compared to the normal electrical deflection. But those cardiologists could actually look at this EKG and actually tell which chamber was enlarged, or which chamber was damaged, or what muscle part was affected by a heart attack. All of those findings can actually be extrapolated from the interpretation of the EKG. So the EKG is not just a window into the electrical system, but it's really a window into the heart, its structure and its function, and quite a remarkable tool. Now that you know the normal electrical system of the heart, you can imagine all the areas that can start to misbehave or malfunction. And one of those areas is located in the upper left chamber of the heart, called the left atrium. And there are these anatomical structures we call pulmonary veins. These structures actually are conduits that bring blood from the lungs that carry oxygen. And inside these veins, there are actually electrical sleeves. And those sleeves can actually trigger and fire and initiate an arrhythmia called atrial fibrillation, which is a very chaotic electrical pattern in the top chambers that overrides the normal pacemaker, which is the sinus node. And so a person goes from normal sinus rhythm to atrial fibrillation based on that trigger or electrical focus. There are other types of arrhythmias that occur in the top or the bottom chamber. That can include electrical circuits. We call a large circuit that involves the entire atrial chamber, either in the left or the right side. We call that atrial flutter. There can also be other types of fast rhythms we call tachycardia that are related to electrical circuits, for example, near the AV node, or foci, firing areas that can exist in either the right or the left atrium. These electrical arrhythmias or heart rhythm issues can also exist in the bottom chamber, the ventricle. And so you can have a scar, for example, from a heart attack that caused injury to the heart muscle. And within that scar, there can be a circuit that can give rise to a dangerous rhythm we call ventricular tachycardia. And so, and also, we talked about electrical channels like the sodium channels and the potassium channels that are very important to the heart cells. Those channels can be abnormal, related to a genetic mutation, for example. And when that occurs, it could give rise to another dangerous rhythm called ventricular fibrillation. So you can imagine now the normal electrical system and areas in the electrical system that may not behave normally, where you could then develop an abnormal heart rhythm that we consider an arrhythmia. So I wanted to bring this slide up to show you how far we've come. This is an example of a mini Holter monitor. It's kind of a misnomer, of course. There's nothing mini about it. This is courtesy of the Smithsonian, and it's from 1976. And many of you are familiar with Holter monitors that you wear with EKG electrodes that give rise to a tracing, and they are quite cumbersome to wear sometimes with all these wires and electrodes. And you sometimes we have people wear them for 24 or 48 hours. So it's amazing to think of this, and then now where we are with very fancy monitors. This is an example of a Zeo patch, which is a device that just is a singular patch that can give the same information that a Holter monitor does from a single patch that one could even shower with. And they could keep this on for 7 days, even up to 2 weeks with data that can be even obtained in real time, which is quite remarkable. And then there are devices that we can even implant under the skin. This is an older generation device made by Medtronic called the Reveal XT. This is a Reveal Link. It's actually smaller than a piece of Orbit's gum, if you can imagine that. And it literally slides under the skin here and can stay there for up to 4 years. And in certain individuals, this can be very important to detect atrial fibrillation or find out other arrhythmias that could be related to a individual symptoms. For example, if they're passing out and we want to know if there could be an abnormal heart rhythm related to their presentation. So this is a very useful, valuable tool, and we can even obtain information from this device remotely and wirelessly and program it wirelessly as well. But even more sophisticated than that, and even just demonstrating how far we've come, many of you are familiar with wearable devices now, such as the Apple Watch and the Cardia device, which just with the touch of a finger and keeping it on your wrist, you can actually record the same type of EKG rhythm strip that you would get from a Holter monitor, which is much more cumbersome and difficult to wear. And this rhythm strip can be very high quality, as you can see here, and very useful. I've had many patients who have come to me with recordings from their wearable device that have helped to diagnose their condition, particularly atrial fibrillation. And I want to bring your attention to a study that was performed. It was actually sponsored by the Apple company, one of the most valuable companies in the world, as you know. They published this heart study, which is published in the New England Journal of Medicine, a very prestigious journal. And it was the largest digital study. It had 400,000 participants. Each of them had an Apple Watch. And of them, the device identified about 0.5% of patients with a irregular pulse and notified them of that. And about a third of those patients were later found to indeed have atrial fibrillation. So the Apple Heart study showed for the first time that this particular wearable device can in fact detect atrial fibrillation, which can be a very important thing to know, as we'll talk about. Very exciting technology. So before we go further, now that you know a little bit about normal conduction system, abnormal heart rhythms, as well as some tools that we use to detect arrhythmias, I did want to make a distinction, as many of my patients tell me about their arrhythmias, but they also want to understand the difference between an arrhythmia, a heart attack, and a murmur. And a heart attack classically is an event that, as cardiologists, we think of is more related to a blood clot that occurs in the arteries that supply the heart muscle tissue with oxygen and nutrients. And when you have a clot that forms in one of those arteries, you have an absence of blood flow, and then the tissue that is supplied by that artery can be at risk for injury and dying, which we call a myocardial infarction. Now, that itself is not a heart rhythm issue or an arrhythmia issue. However, that muscle that then is impacted by that injury can later give rise to an abnormal electrical circuit that we alluded to earlier, called ventricular tachycardia. And so even though a heart attack is not exactly a rhythm issue, it can be associated with rhythm issues either at the presentation by giving rise to dangerous ventricular arrhythmias, or in the future, giving rise to ventricular arrhythmias, or with changes in the heart, even atrial fibrillation. So there is a relationship, even though they're not exactly the same thing. The other thing that people almost sometimes tell me is that at some point in their lives, they were told they had a heart murmur. And when cardiologists think of heart murmur, that also is different from a heart rhythm issue. However, they can be related. Heart murmurs typically have to do with someone listened to a heart with a stethoscope and identified an abnormal flow of blood through the internal chambers of the heart. And that usually happens when valves inside those chambers become diseased. And sometimes those valves can become narrow or cause stenosis, or they can leak and cause regurgitation. And that can give rise to not only the sound of a murmur, but over time, you can see how these valves are intimately associated with the electrical system of the heart. So that those valve issues can give rise to other heart rhythm abnormalities, including atrial fibrillation or ventricular arrhythmia. So again, there's a relationship between arrhythmias and valve disease, but an arrhythmia or heart rhythm disorder is not exactly the same as a heart murmur. So when we think about heart rhythm disorders, we like to characterize the heart rhythm issue based on the individual that we are seeing in clinic or in the EP lab. And we want to first categorize the heart rhythm based on how it is impacting that individual's quality of life. What types of symptoms are they having? What are they not able to do like they used to? How is this arrhythmia affecting their day-to-day life? We also like to categorize these rhythm issues in broad categories. So if it's a fast rhythm issue, we call that tachycardia. If it's a slow rhythm issue, we call that bradycardia. If it's involving the top chamber, those are atrial, or what we call supraventricular, above the ventricles. If it's impacting the bottom chambers, originating from the bottom chambers, those are ventricular arrhythmias. And this is where, even though we're electrical specialists of the heart, we like to put on our cardiology caps and our internal medicine caps, because we need to understand why these arrhythmias develop in a particular individual. And oftentimes there can be other associated cardiac conditions, things we've mentioned, such as a history of a heart attack or history of valve disease, and other medical conditions, for example, history of sleep apnea or thyroid diseases, or other medical conditions that like high blood pressure. We also want to understand the arrhythmia so that we could help prevent potential complications in a particular individual. For example, if someone has atrial fibrillation, we know that a potential complication of that arrhythmia is stroke. So we need to assess their risk of having a stroke, and we need to find ways to reduce that risk. And so it's very important that we understand the arrhythmia. Therefore, then we can then address the risks associated with that arrhythmia and treat them accordingly. And through all of this, what we are aiming to achieve is optimal management of the patients. And typically this is tailored to the individual, as there are a wide variety of strategies and wide variety of symptoms. And we really need to treat the arrhythmia according to how it's impacting that particular individual. And when I say full court press, what I mean is we need to effectively treat those associated heart and medical issues that are associated with those rhythm issues. And our goal, of course, is to improve quality of life, improve survival, and do no harm. Palpitations are one of the many different types of symptoms associated with arrhythmias, but people can present with various types of feeling poorly. They can have chest pain, tightness, dizziness, lightheadedness, shortness of breath, fatigue. Sometimes it can be very subtle. For example, atrial fibrillation. I'm often told that by a significant other that their husband or their wife is just going to bed sooner than they would otherwise normally. So it's very important to assess how these rhythms can impact different people. And the same rhythm can be perceived differently from one person to the next. There are also what I call red flag symptoms. So if someone feels like they're going to pass out, or if they pass out, that is a red flag. It's a very serious issue that we need to get to the bottom of to make sure there's no associated heart rhythm abnormality that's causing that issue. And we call that syncope. What is the impact of heart rhythm disorders? Well, more than 14 million Americans have heart rhythm disorders. Atrial fibrillation is probably among the most common arrhythmias that we see, and more than 6 million people in the US have atrial fibrillation. This is expected to double by 2030. 1 in 4 adult Americans over the age of 40 could develop atrial fibrillation at some point, even if they've not had a prior history of heart disease. 1 in 6 could develop atrial fibrillation. And as you know, AFib is one of the leading causes of a stroke. And in older individuals, it can increase the risk of stroke up to 5-fold. So it's very important that we detect atrial fibrillation and address the risks associated with it. A different type of arrhythmia coming from the bottom chamber we alluded to earlier is called ventricular tachycardia and ventricular fibrillation. This is a very serious category of arrhythmias. These arrhythmias can be associated with a cardiac arrest. More than 350,000 people in the United States die each year as a result of sudden cardiac death or sudden cardiac arrest. Although the majority is related to a history of heart attack or myocardial infarction, we oftentimes see younger individuals that can still be at risk related to an underlying genetic heart condition, either a genetic condition that affects the heart muscle or the electrical system that we discussed at the beginning. So these are two critical areas of our field that we focus on: atrial fibrillation and ventricular arrhythmias that can cause sudden cardiac death. I want everybody to be reassured that heart rhythm disorders can be treated effectively. And I just wanted to make a few sentences here that will help answer and relieve some anxiety. Some arrhythmias can in fact be cured. There are certain types of arrhythmias that we call SVT, where a procedure that we do commonly called a catheter ablation can actually cure that arrhythmia, where it can no longer cause symptoms or problems as an individual gets older. There are other arrhythmias that can be cured as well: premature atrial beats, premature ventricular beats, atrial flutter. Even these are just examples of arrhythmias that we can cure. Cardiac pacemakers can take over for parts of the failing conduction system. Millions of people have pacemakers and they live very normal lives with these devices. Cardiac defibrillators can restore normal rhythm when a dangerous ventricular arrhythmia occurs. These devices have been shown to save lives. Atrial fibrillation can be controlled. Stroke can be prevented. We have newer therapies, newer options for patients with atrial fibrillation, and we're hoping that a cure is on the horizon as our research and understanding of this arrhythmia expands. And then sudden cardiac death can be prevented. These are some important points to take away, that we can effectively treat any heart rhythm disorder, provided that we take care of the patient, detect these arrhythmias early, and follow patients closely. AFib, I just want to mention some of the other impacts of atrial fibrillation and point out some of these statistics. Worldwide, and this is an underestimated number now, 33.5 million people have AFib, and this is almost 10% of people above the age of 65. So it's a significant issue. Billions of dollars are spent by our health system every year to treat atrial fibrillation, and you can imagine now why a company like Apple wanted to focus on atrial fibrillation as one of its first conditions related to the Apple Watch diagnostic capability. Atrial fibrillation can cause decrease in quality of life. It can increase the risk of stroke. It can contribute to the development of congestive heart failure or cardiomyopathy, which is weakening of the heart muscle, and it can be linked with dementia as well. Risk factors for atrial fibrillation are aspects that some of which we can control, some of which we can detect and treat early. So aging, presence of diabetes, presence of high blood pressure, or heart failure, or vascular disease. These are very important to detect early and treat to prevent atrial fibrillation. And sometimes atrial fibrillation can be present based on a family history and the presence of a genetic predisposition. And of course, there are other medical issues: obesity, obstructive sleep apnea, alcohol and stimulant use that can also be a trigger for atrial fibrillation. And then some people have atrial fibrillation even in the absence of risk factors, even with a structurally normal heart, based on an electrical predisposition that often has a genetic link. In the past, the only treatment for atrial fibrillations was a medication. And these are some abbreviations of commonly used medications. You might recognize some of this: amiodarone, dofetilide, sotalol. And you'll see that the maximum efficacy in terms of keeping people in normal rhythm is limited with medications. At best, 60%, 65% efficacy with medications. So you can imagine we needed something better. We needed something better to get from old days of DC planes to current 787 or rabbit ears to a satellite, or even now wireless internet streaming. So fortunately, the treatment of atrial fibrillation has been revolutionized in the last 10 to 20 years, and it continues to get better every day. And now we can detect atrial fibrillation early and come up with more aggressive treatments sooner. As you saw, there are advances in heart rhythm monitoring. Early management, we know now with clear data in patients, when we are aggressive about treating their rhythm with newer therapies that are safer, we can help delay progression of atrial fibrillation, help them feel better, improve quality of life. One of the mainstay treatments for atrial fibrillation, instead of medication, has now become a catheter-based procedure that we call ablation. And there are new technologies for mapping. There are new understanding of the genetic basis for who can develop atrial fibrillation, and there are better treatment for the other conditions associated with atrial fibrillation. And now we can really help prevent stroke. It used to be historically the main medication we had to reduce stroke risk was Coumadin or warfarin. Now we have newer blood thinner medications that are safer and more effective, although a significant limitation does remain cost for patients currently who cannot be on these blood thinners because they have a higher risk of bleeding, or they've had bleeding issues in the past. And now we can place devices in the heart to reduce that risk of stroke as well. So tremendous advances in atrial fibrillation. Our catheters have improved, our ability to understand atrial fibrillation in the heart has improved, and our ability to assess risk of stroke and treat that risk has improved too. I do want to take an aside and mention that the warning signs of a stroke, everybody should know this: any weakness or numbness of the face, leg, arm, confusion, trouble speaking or understanding, trouble walking, dizziness, loss of balance, severe headache with no known cause. These are symptoms that should not be no one should wait. They should be very much important to detect early, and people with these symptoms should seek medical attention. When we the way we assess someone's risk of stroke related to atrial fibrillation is actually we calculate a score called the CHADS-2 VAS score. So if an individual has a history of vascular disease, high blood pressure, advanced age, diabetes, or a history of stroke, if they get 2 or more if they're male, or 3 or more in females, because females do have a slightly higher risk than males of stroke, then we recommend a blood thinner or some form of mitigation to reduce their risk of stroke. And for people who can't have a blood thinner, this is a device that we can actually put into the heart now called the Watchman device. We go inside the heart with a catheter. We deploy this device inside what's called the left atrial appendage. This is where the maximum number of blood clots can form related to atrial fibrillation that can give rise to a stroke. And by deploying this device in this location, we can prevent communication of the remainder of the appendage with the rest of the heart and prevent those strokes from occurring. So for atrial fibrillation, we really want to develop a tailored strategy. We want to detect and treat this as early as possible. We identify lifestyle changes, avoid triggers. We identify the optimal rhythm control strategy when beneficial, and we identify the optimal strategies to reduce the risk of stroke. New technologies may make atrial fibrillation ablation safer and more effective in the future. Atrial fibrillation management is a long-term strategy. And for some, ablation may not be the best strategy. For some, it may be medications. Others, it could be cardiac pacing devices in conjunction with medications, or what we call AV node ablation. Sometimes just controlling the rate for certain individuals is sufficient to help them live high quality lives, and close surveillance to avoid complications of atrial fibrillation such as stroke and congestive heart failure. I'm going to change gears quickly here and briefly touch upon sudden cardiac death. October is actually a month that has been set aside for Sudden Cardiac Death Awareness Month. And sudden cardiac death is typically associated with the ventricular arrhythmias we discussed, ventricular tachycardia and ventricular fibrillation. And fortunately, in the last 20 years, our field, cardiac electrophysiology, has advanced so much that now you'll find that these defibrillators are fairly common. It's hard to go to a public space and not see a automated electronic defibrillator that's there that can be used to save someone's life if they collapse related to a cardiac arrest. And now we're implanting these devices for patients who are at risk of sudden cardiac death, and we can help prevent a sudden cardiac arrest if they have a dangerous arrhythmia. You may recall this image, which was a very horrifying image that occurred during the Euro Cup, where a player, Christian Eriksen from Denmark, collapsed on the field. His teammates literally circled around him as the EMS worked on him to help resuscitate him. He was actually defibrillated by an AED along with their CPR and advanced cardiac life support protocols, and he survived. And he had an implantable defibrillator implanted, and he actually has returned to the soccer field with that device in place and is playing at an elite level. And he's only 29 years of age. He's someone who's had many health checkups through the years, but these conditions can be difficult to detect and understand, but this is the mission of what we call the Genetic Arrhythmia Center. We have a center at Minneapolis Heart Institute that focuses on young individuals who are at risk for sudden cardiac death. And in doing so, we have created what we call the Sudden Cardiac Arrest Network. So in conjunction with medical examiners, our colleagues at Children's Hospital, our cardiology colleagues, as well as counselors, genetic counselors, and researchers from Minneapolis Heart Institute Foundation, we have put together a center where we treat patients who are at risk of sudden cardiac death, as well as their family members. And we hope to identify patients who have genetic conditions that we can help prevent sudden cardiac death with risk stratification and implantation of a defibrillator when necessary. So, as we run short on time, I just wanted to say that at Minneapolis Heart Institute, we are really dedicated to cardiac device safety and innovation. As you can see, the Genetic Arrhythmia Center exists to treat these patients. We collaborate with partners around the world. We excel at state-of-the-art care for large volume patients, but really we're passionate to put the patient first and provide world-class care. And we think big when it comes to advanced therapies, research, and innovation. Thank you.
All right. Well, thank you very much, Dr. Sengupta, for that excellent presentation. And hello, folks. My name is John Rickert. I'm the virtual event lead here at the Minneapolis Heart Institute Foundation. And thank you again for joining us today. At this point, we have reached our Q&A portion. And for today's session, the questions that we have prepared came through via registration. Please do still submit questions via the Q&A pod located at the bottom of your Zoom screen. The way that you access that is you drag your cursor across your Zoom screen, access the toolbar at the bottom of your Zoom screen, and click on that Q&A pod. And just know that you may submit questions anonymously. They may be addressed in future on the Pulse sessions. So Dr. Sengupta, the first question that we have, and this is actually a common question that I've seen in other on the Pulse sessions, and it has to do with holistic and natural treatment options. So the question is, are there any holistic natural ways to either stop AFib from happening or to lessen the occurrences of AFib?
Yeah, this is a great question. And it is something that we like to focus on because there are definitely lifestyle choices that can impact atrial fibrillation burden. And so starting with triggers for atrial fibrillation, avoiding, for some people who may be very sensitive to alcohol or caffeine or sugary drinks, I've heard a number of potential triggers in various individuals. And sometimes it's as simple as avoiding those triggers that can significantly impact their atrial fibrillation burden. And Now, some people, and most people, in fact, don't have, or it's very hard for them to identify any triggers at all. Atrial fibrillation just comes and goes as it pleases. But when there are triggers, it can be very significant. I have a particular individual patient who he knows if he drinks a glass of alcohol or a glass of wine the night before, that most likely he's going to have AFib the next day. That's pretty extreme, but that's one possible important aspect to identify if an individual is sensitive to that. As far as holistic or alternative treatment medications, there aren't currently anything that has a large amount of data behind it. And I would caution people from finding data related to small studies. I would bring up the fish oil example. It was thought based on very tiny, small studies that fish oil may help prevent atrial fibrillation. And then there was a large prospective randomized trial with many patients looking at fish oil, and in fact there was a signal that in the fish oil group arm, there was actually a little higher incidence of AFib, and now there's a warning associated with fish oil and AFib. And so it's very important that when we make recommendations regarding treatment options for AFib, that we have very good, valid, and vetted data on which to make those recommendations.
Yeah, totally. That makes a ton of sense, and thank you very much for that response. So the next question is, what are some of the most common triggers that cause arrhythmias or AFib?
Yeah, so common triggers can be related to diet and food. So alcohol, caffeine. Caffeine can sometimes increase our predisposition to premature beats, which can then trigger atrial fibrillation. So someone might feel more palpitations if they're taking extra caffeine. So, and I really frown upon certain types of caffeinated beverages like monster drinks or 6-hour energy drinks, because it's a large amount of caffeine and caffeine-like compounds that can be taken in a very short amount of time. And oftentimes, if people are exercising or really increasing their heart rate after such intake, that can be even more of an issue and a trigger for atrial fibrillation and other arrhythmias. So those are important. For some people, it can be exercise mediated. So we do have a group of patients who have performed in Ironman competitions and triathlons, and sometimes we have noticed that there is a higher incidence of AFib in that particular group. And that can be particularly associated with intense exertional physical activity over a long period of time. So something else to keep in mind. But, I've seen many people complain of different triggers, whether it's sugary drinks, cold beverages, caffeine, alcohol. It's all about, for a particular individual, identifying if that's the case, and then taking common sense steps to avoid those triggers if possible.
Yeah, makes a ton of sense, and thank you very much for that response. So I guess the next question that I have here from an attendee is, can arrhythmias be totally cured?
Yes, so there are some arrhythmias that in fact can be cured. Oftentimes with a catheter ablation procedure, I alluded to that earlier during the presentation. There are some types of SVT. You may have heard of a condition called Wolff-Parkinson-White syndrome. These arrhythmias can in fact be cured with a catheter, and in some people these arrhythmias were part of the triggers for their atrial fibrillation. So our ablation procedure has come a long way. We're very happy to report that there are some rhythm disturbances that can be cured, but I would say also that most of the rhythm disturbances we've touched upon can be treated, and even if they're not cured, they can be effectively managed and contained, and we can help people live very high quality normal lives and even improve their survival and avoid complications. So all of these arrhythmias, we're working to develop new treatments, and we're very optimistic about treating arrhythmias regardless of whether or not they can be cured.
Fantastic. Thank you very much for that. So I guess a follow-up question is, if someone were to have a heart rhythm episode, what are the best ways to recover?
Yeah, so very good. And it's a very good question. So some heart rhythm episodes can be very symptomatic. So if an individual has a bout of atrial fibrillation, some people are very symptomatic where the rest of their day is shot, or they feel very fatigued, out of breath, and it takes some time to recover. So in those individuals, it's really about avoiding the episodes and coming up with a treatment strategy to prevent the arrhythmia from occurring, and treating the arrhythmia so that the symptoms are minimal at best. And there are, of course, other individuals who may be asymptomatic. And so that's even in those individuals, though, we want to make sure that the arrhythmia is not causing other problems, such as weakening of the heart muscle or congestive heart failure. So we need to identify how an arrhythmia impacts a particular individual, and then we come up with tailored strategies to try to recover from that and prevent that arrhythmia from happening.
Absolutely. Thank you very much for that. So are arrhythmias hereditary?
Yes, arrhythmias can definitely be hereditary. And for atrial fibrillation, we're just at the beginnings of understanding the genetic makeup for risk related to atrial fibrillation. But there are many different arrhythmias that can be hereditary, or at least genetic conditions that can give rise to the risk of developing a heart rhythm. And I briefly mentioned the Genetic Arrhythmia Center. So in that clinic, we study young individuals who have genetic conditions that can give rise to heart muscle or cardiomyopathy related problems like hypertrophic cardiomyopathy or arrhythmogenic cardiomyopathy. Those patients who develop a cardiomyopathy may be at higher risk of ventricular tachycardia and ventricular fibrillation. And so that's how we have to treat their underlying cardiomyopathy and their risk for ventricular arrhythmias to help protect them against sudden cardiac death. And then there are other individuals that may not have a cardiomyopathy, but may have a genetic mutation in their sodium channel or potassium channel, which we talked about during this presentation. And for those individuals, their risk of developing a ventricular arrhythmia may be different, and we have to address that risk. And sometimes we oftentimes recommend medications or treatment strategies like a defibrillator to protect them against ventricular arrhythmias. So hereditary, there is a hereditary basis for certain arrhythmias, and we try to understand that, identify that, and treat that as effectively as possible. And genetic testing is expanding and improving, so we're learning more and more about these genetic conditions every day.
Thank you very much for that. So if folks are interested in learning more about the research that you facilitate and lead, where can they go to find out more?
Yes, thank you. Yeah, we're very fortunate. We have a tremendous research group in the Minneapolis Heart Institute Foundation, and that information can be available on the website. It can be available through contacting us or our clinics, staff, and oftentimes we're thinking about potential options when we're visiting with patients, if it's the best option for them. And but I would refer people to our website, and also with upcoming events in the Minneapolis Heart Institute Foundation that I can't go into detail right. Exciting time for research in our foundation, and so there's definitely more to come with respect to heart rhythm research in our center.
Yeah, and that's really exciting, which leads me to my my next question, which is, what are you most excited about regarding the future of heart rhythm research?
Yeah, I'm very excited about this field, and I really, it's really an exciting field to be in because it really encompasses all the aspects of becoming a physician. There's an art to practicing medicine as well as a science. And in this field of electrophysiology, we have many different options to treat our patients to help them achieve their goals with respect to these conditions. Sometimes that's about reassurance and following them over time, making sure they're doing okay. Other times it could be a medication or a device or procedure strategy, but it really depends on the individual. And I'm really excited that we can offer so much to help our patients live normal, fulfilling lives and avoid the complications of potential that are related to these heart rhythm disorders.
Absolutely, and I think the future is really bright in this area, and some of the research that's going on is just fantastic. So a lot of exciting things on the horizon here. So at this point, I think we've kind of reached our time here. So do you have any final thoughts for the audience?
Well, I would say that it's very important that I hope a takeaway is that this has increased the audience's understanding of heart rhythm disorders and how it impacts our lives, and it can impact so many people. And I think it's important to pay attention to one's symptoms. So if there are symptoms that we talked about during this presentation, and it's not clear, I think this will empower patients to seek out help from their physicians. Also, there are now tools such as the wearable devices we spoke about. So there are many ways of going about addressing those symptoms and getting to the bottom and effectively treating a heart rhythm condition if it's diagnosed. So I'm very excited, and I hope that patients and people who are listening will pay attention to those aspects of this presentation.
Absolutely. Well, Dr. Sengupta, thank you very much for your time today. We really appreciate your time and expertise. And to the folks joining us online, thank you so much for joining us, and have a great rest of your day. Thank you.
Thank you. Bye.